Well, good morning, everybody. Welcome to Grand Rounds. Let me mention that next week's Grand Rounds will be the Department and Institute's annual meeting, and it'll be virtual as we have been meeting this past year. I want to encourage everybody to attend because it will be not the usual type of format. It'll be a look back, but it'll also be really looking forward based on what we've experienced in the past year, new initiatives that have sprung from the experience, and an effort to try and come out of the COVID pandemic era into what we perceive to be a new normal or a new environment for healthcare and mental health care delivery and academic medicine. So you'll get a sense of what form that's taking. In addition, this is good and bad. I'm going to slap the hands of the organizers, even though there are luminary researchers and faculty members and are staging an excellent conference, a Depression Center conference next week. That's Dr. John Mann and Randy Auerbach, who have programmed a 3-day series of talks among the stellar researchers across the country on depression. And it'll take place on next Wednesday, the following, or it's June 9th, June 16th, and June 23rd. So you'll notice that the June 9th, the first day of it, coincides with the annual meeting. So if you are attending the depression conference, which I encourage you to do, you'll have to drop off to attend the annual meeting. And John and Randy will understand that. And I hope they haven't programmed me to be speaking at the same time of the annual meeting in the Depression Center conference. But those are two important things that'll be very informative. And then I also wanted to make some announcements about, well, let's see. No, I guess that's it for announcements. Okay, well then we can get to the Grand Rounds agenda and introducing our speaker. And this is really an interesting occasion because, as so often happens in the context of busy professional lives within academia or in New York City, is that you have to go somewhere else to meet your neighbors or your colleagues. And in this case, this is what's happened, and somewhat embarrassingly, with Dr. Ashwin Vasan, who is currently the president and CEO of Fountainhouse, a position that he took, was selected for in 2019. But before that, he had really a storied career in global health and in academic medicine, including most recently, prior to his assumption of the role at Fountainhouse, in our own School of Public Health and Department of Medicine. So how did we never meet him and really engage with him in some collaborative interests? Well, I'm not going to necessarily tell you, but hopefully we'll be able to make up for that in the future going forward. But Dr. Vasan received his bachelor's degree in economics at the University of California, Los Angeles. He received a degree in epidemiology at the Harvard School of Public Health. Then he received an MD at the University of Michigan, and then a PhD in public health from the London School of Hygiene and Tropical Medicine. He did his postgraduate training in medicine at New York Presbyterian in Columbia, and maintains a position on the faculty in Department of Medicine and also in the School of Public Health. But in the course of his postgraduate training, he's embarked on really a peripatetic and very diverse career. He's involved with various organizations, including as a technical officer for the Department of HIV and AIDS with the World Health Organization. He subsequently was involved with an integrated management team for adolescent and adult health in the WHO. He was deployed in various locations around the world, including Africa, as well as Europe. He also had assumed a role within the WHO as a consultant for clinical programs and training with an organization called Partners in Health in Rwanda, and so on and so on. I won't go through all of these, but Eventually, he decamped back to the United States and to Columbia in the School of Public Health, where he was executive director and founder of the Health Access Equity Unit, and then assumed the role of president and CEO of Fountainhouse in 2019. I asked him before, how did he sort of make the how did he develop his interest as coming from global health and medicine to mental health and serious mental illness? And he explained that in a way that I found to be something that I had been feeling for a long time, but hadn't heard expressed so eloquently by others, which is the negligent and inadequate care of persons with mental illness, and particularly SMI, is not solely a healthcare disparity or an unmet clinical need. It's really a social justice issue, and that'll be his topic today. So I'm glad that his talk will be well attended, and I hope it'll be really a jumping off point for us to engage with him and with Fountainhouse in what's really kind of a renaissance, programmatically speaking, that is by virtue of what he has told us, in the programmatic initiatives of what's been really a legendary institution in mental health care going back to the 1940s. So please welcome, somewhat belatedly, Dr. Ashwin Vasan.
Thank you, Jeff. Thank you, John, for having me. Let me just try to share my screen first before we move on. Okay, are we good?
Yes.
Yes, okay, very good. So thank you for that kind introduction, Jeff. And I think you used exactly the right descriptor, which is a little bit peripatetic, my career to date. But, you know, professionally, the theme that has really tied together the different experiences, I started my career in global HIV at a moment in which we were debating as a society whether we should be investing in treatment of low income people in low resource countries in the global south when people in the global north had been accessing life-saving antiretrovirals for the better part of the decade prior. And we were arguing that, and it wasn't until I saw that framed as a social justice issue by activists and by, you know, physicians and anthropologists like Paul Farmer that I was really captured by that framing and captured by the idea that this is actually a fight. It's one that clinicians like ourselves and public health people have an obligation to raise up those inequities and that injustice in order to redress those gaps in access to and quality of care. And so I spent the better part of the first decade of my career, including my time as a trainee, as a medical student and as a trainee, working on that issue. And it really has framed my approach to everything I've done subsequently, even if I have moved around. I'm very grateful to Columbia for the home, the academic home and the clinical home they've provided me for, going on 10 years now. And, more than 10 years now, I guess. And, it's been a great place to train, a great place to learn from my colleagues, and also a wonderful launching out point for work that I've done at the New York City Health Department and now at Fountainhouse. And so, Jeff, I think you shouldn't feel too bad that you haven't come across me, because I'm also new to this work, and I recognize that, and I acknowledge that. And so I'm also acknowledging that I'm in a room here, or a virtual room full of experts. And so I think what you'll hear from me today is really my framing of serious mental illness as a social justice and as a public health crisis, told from an outsider's point of view. I'm truly an outsider to mental health. I'm an outsider to behavioral health and to SMI, but I've certainly worked on it in intersections with homelessness, with justice involvement, with trauma, and with refugee populations, certainly in the work that I did in Rwanda and with HIV. But why I took the job at Fountainhouse, and I was explaining this to Jeff and to Jonathan before, not only did I feel like it was thematically consistent and professionally consistent with the kinds of work that I've done on health equity and vulnerable populations, but I'm also the family member of people who live with and who have lost their lives to serious mental illness. And I think for those of you in the audience, particularly from immigrant communities or communities of color, I think you can appreciate how difficult that is for even me to say in a public forum, right? Because these are issues that we've really chucked under the rug for so long and stigmatized. And I think at the root of so much of the public policy failure in addressing mental health and serious mental illness in particular is that stigma and is discrimination that is an outgrowth of that stigma. And so I felt like it was a wonderful opportunity to take a historic organization into its new era to really build something transformative at a moment when mental health was already becoming a more widely accepted part of the public conversation. Little did I know that 4 months after I started, we'd be in the midst of a global pandemic where now mental health is, on every front page headline each morning for good reasons and for bad, of course. But I think this is exactly where I need to be. And I'm just grateful to be here with all of you and looking forward to the conversation and looking forward to, potentially building out further collaborations with my academic home and my clinical home. And I just want to also call out folks like Stephanie Lamel and others who have already, and Kathy Pike, who've already been longtime supporters and collaborators with Fountainhouse, and just in my short time at the institution have been great sources of partnership and support. So I feel very much at home, and thank you for having me. So let's get started. If I can only advance the slides. There we go. So yes, my disclosures, I think you can see them. I'm not going to belabor them. The objectives of today are really to outline my take on the crisis of serious mental illness in the United States, the failures of our existing health and social systems to address it in any meaningful way, and the need to marshal resources and to approach it as a public health crisis if we're going to turn the corner. It's to provide a little bit of background on Fountainhouse for those of you unfamiliar. I think most of you will be quite familiar with it, but also where we plan to go in terms of our new strategy and vision for the future, and to then bring it back to some of the rights-based framing that really has informed my work since the beginning, since the start of my career with HIV. This work of centering public health work around rights and dignity and around civic inclusion and civil rights has really informed my thinking in framing this as a social justice issue. And I think it's the right opportunity now to marshal that kind of movement and to put together that kind of movement. So that's what we'll try to go through today. I'm going to try to finish my remarks by noon, and then we have about half an hour to discuss. Okay. So serious mental illness as a public health crisis. What makes a public health crisis? Generally accepted that it's when the health consequences of an issue really begin to overwhelm or outstrip the routine community capabilities to address them. It's not lost on me, the irony that we're obviously in the midst of a public health crisis as I'm saying these words, but clearly a negative impact on health outcomes is a starting point. Preventable morbidity and mortality is kind of the driver behind why we frame things as health issues and as public health issues. It has to, of course, affect enough people. These aren't neglected diseases, neglected tropical diseases in those classic framings. These aren't orphan diseases. These are actually diseases that are affecting a significant fraction of the population across geographies and across demographic groups. They're diseases and conditions for which there are social risk factors and impacts, social determinants of health, which have very clear intersections, of course, with public policy and what drives and creates those conditions. and of course, an increasing public awareness of the issue, which I think we are seeing with mental health and with serious mental illness. I'm going to continually draw parallels to the work that has really formed the foundation of my career, which is in global HIV, where not only did we really see ripple effects of the pandemic, the HIV pandemic, but it wasn't until a combination of activists, scientists, and public health people really responded to it as a public health crisis that we started to see change being made. So that's really the framing of how I approach this issue. Part of why I came to Fountainhouse to begin with. So I'm struggling a little bit with advancing the slides. As I suggested, serious mental illness really does have ripple effects across individuals, families, and communities. On an individual level, I think we're all aware of this data. Anywhere up to a quarter of a century loss of life and shorter lifespans for people living with serious and persistent mental illness, 2 to 4 times more likely to die from unnatural causes, much higher rates of chronic comorbidities. Obviously, we know some of the risk factors: medical neglect, tobacco use, dietary and activity issues, but also infectious diseases, higher rates of infectious diseases in this population, including HIV. 20% more likely to experience substance use disorders. This also reflects in our responses. And we don't need to, I have historians in the room who will educate me on the trans-institutionalization and the phenomena behind that. But what's very clear is that we criminalize serious mental illness in a very particular way in this society. People with SMI are admitted to jail 2 million times per year in the United States. About 20% of them, of current inmates at any given time, are living with serious mental illness. They're overrepresented in our chronically homeless population, or in our homeless population writ large, but as well as our chronically homeless population. Lower rates of unemployment, lower rates of earning and income inequality, income insecurity, economic insecurity, and of course, lower rates of attainment of educational goals. So across the board, that sums to people, individuals who are really afflicted as much by the condition itself as by all of the co-occurring physical and social factors that compound and end up leading to much lower quality of life and much shorter lifespans. Obviously, there are ripple effects on families for those folks who have family engagement, who aren't socially isolated to the extent that they're disconnected from families. You've got 8.4 million Americans providing care to an adult with a mental health issue. You've got unpaid labor impacts. You've got loss of productivity and earnings for those people, long-term physical and mental health impacts for caregivers. So this is clearly not just an issue that's limited to families, or it's to individuals affected, but to the folks caring for them. And of course, the community and population effects, economically and otherwise. We look at 200 billion in healthcare costs due to mental illness. 1 out of 8 ER visits in the US involve mental illness and substance use in some way. Almost 13% of total Medicare spending associated with mental health disorders, which is actually quite ironic when you think about the shortened life expectancy of people with SMI. Many of them don't even make it to 65 to be on Medicare. And then amongst the folks who do, they're still engaged in cycles of high cost, high utilization, lower quality care. Total economic losses in approaching 200 billion to society. Criminal justice costs, associated with those 2 million jail admissions, and overrepresentation in the prison population. In 2019, as you well know, the largest providers of mental health treatment in the country are 3 of the largest county and city jail systems. And of course, overall increased welfare and social service costs. We know that folks with serious and persistent mental illness are eligible for disability under the ADA, disability rights, and SSD payments, SSI and SSD payments. For those who even avail themselves of those things, that's quite an additional burden to our public administration systems. The famous Vikrams and other folks who were involved, I'm sure plenty of them in the room, in the Lancet Global Mental Health Report in 2018 estimated $16 trillion in lost productivity due to mental health disorders in the next 10 years, over the last 10 and 20-year period till 2030. So this is, our neglect of this issue from a public policy and public health perspective is at our own peril. We're going to be dealing with this one way or another. It behooves us to step up and marshal the kind of intersectoral approach and cross-government approach and cross-private sector approach to really address this. There's obviously embedded inequalities, disparities, inequities in our mental health system. We know that access to mental health treatment is systematically and significantly lower for Black Americans. We know that 1 out of 3 Americans, according to Kaiser and according to HRSA, lives in a mental health professional shortage area. That's 111 million Americans. Those are people that when they need mental health care have difficulty accessing it, either due to geography or financial or other barriers, lack of coverage. And the majority of those people are people of color and people living in rural areas. We know that there are economic impacts of mental health. The UK government has done a fantastic job of their money and mental health initiative. I think we need to be doing something similar here, but African Americans living below the poverty line in particular, 2 times more likely to report significant psychological distress. Half of Black adults who need mental health care for serious conditions receive it. So that's half that don't. And we have a serious workforce problem. I think we can all agree that culturally competent care in all forms of healthcare is essential. It's particularly important in behavioral health care, where trust and trust and therapeutic alliance is even more important in terms of sustained engagement into care. And 86% of psychologists are white, and we need to be focusing on the training of and the development of a much more diverse behavioral health workforce. And so it would be remiss of me to talk at this population level and to not call out some of those embedded and structural disparities. And of course, we know that this was all happening right under our noses for the last 20 years. You've all been fighting against this and working on this for a long time. We've had increasing rates. Deaths of despair are simply just one metric to suggest that we have a behavioral health crisis. But I think you're all familiar with that terminology. But for those who aren't, deaths from suicide, from the effects of alcoholism, or the effects from drug overdose, we've seen that increase over the last 20 years. We've seen an inflection point in the last 10, really associated with the opioid epidemic, and that was all pre-COVID. We know that there are 13 million Americans living with serious mental illness. That's about a stable 4% of the population. That's fairly even across demographic groups, even though schizophrenia in particular, schizoaffective disorder and schizophrenia certainly has a long and racialized history of diagnosis for Black Americans. We know that close to 50% of Americans were projected to develop a mental illness across some point in their lifetime, from half of them doing so by age 14. And so we've seen this growing tide, and there has been a call, certainly within your world, but as an outsider coming into this space, I can tell you that it's been undercovered, it's been underappreciated, and the public health community has not really been taking it as seriously as it should be. And then COVID came. And these are just a range of some of the survey data that we've seen, whether it's from CDC or Kaiser or NAMI, in increases in the impact, the impact of COVID on mental health, depression symptoms, anxiety symptoms, suicidal ideation symptoms, substance use increases, higher prevalence of depression symptoms in the JAMA survey from last summer that was just, I think, recently redone. And of course, we've seen increase in helpline calls. We've all experienced some approximation of the same stressor. I think especially here in New York when we were really on lockdown for the early phases of the pandemic. And we've seen that have short and potentially long-term effects on the mental health of all of us. Certainly children are going to bear a major brunt of that. I'm the parent of 2 school-aged kids. I've watched them really suffer and struggle with remote learning and have some really regression in their behavior and their emotional development, social and emotional development as a result. And that's going to take a long time, I think, to rebuild and to recapture now. And we're a family that's privileged and we have the opportunity to provide support. What happens for folks who aren't? So we have to be really addressing some of those issues. I've been calling this in public. I do a lot of sort of media appearances given my organizational role. And I've been calling this the second pandemic of mental illness. And I don't use that terminology lightly. I don't use it for effect. I use it because I honestly think we're going to be dealing with a long tail and a systemic increase in mental health issues over the next decade or more. I think our children are going to bear the brunt of it, but I think even as adults, it's going to take us some time to recover from the new mental health diagnoses that have arisen due to COVID, or at least have been diagnosed in the wake of COVID, from exacerbated mental illness, pre-existing mental illness due to COVID, and all of the social and economic insecurity that has been foisted upon people that has mental health impacts that we're just going to be unpacking for years to come. And my worry is that the system is structurally unprepared to deal with this coming wave. We don't have enough mental health care. We don't have the right kind of mental health care, and we don't have the right kind of supports around mental health care to really support people in their long-term recovery and living with serious mental illness. We know that mental health, with mental illness and serious mental illness, we know that mental health overall is underfunded. And in a $3 trillion health system, only 7% of that funding goes to behavioral health. Only 1.3% of all private foundation funding went to mental health over the last several years. It's especially pronounced for serious mental illness. I kind of alluded to the fact, and you all well know, that jails and prisons often are the provider of first resort, especially for people living with serious mental illness of color. Nearly 40% of people are not in any care at all across the country. So of the 13 million people, nearly 40% of them are living with serious mental illness and not engaged in any durable care. And community health programs, community mental health programs like Fountainhouse and others really struggle to leverage funding and to have a seat at the policy table. I think it's really driven mostly by provider groups, by hospital associations, by industry. And frankly, community mental health is shut out from the discussion in terms of leveraging resources, leveraging directionality of resources. We've seen over the 3 stimuli that have passed in May 2020, December 2020, and now most recently the American Rescue Plan, the first new money for mental health specifically in 15 years. That's the first new money. SAMHSA's budget has not grown at all in 15 years in any meaningful way. And this approaching, $10 billion is a drop in the bucket, but it's the first new money. And it's a recognition, I think, that in this time of crisis, that the administration is finally starting to regard the mental health impacts of the pandemic and the underlying and pre-existing mental health epidemic we had in our midst as a responsibility for them to address. So I'm slightly optimistic, but there's still a long way to go in terms of baking a much bigger pie of mental health resources at the federal level, which obviously trickles down to states and local authorities. Most of the public funding that Fountainhouse gets is actually SAMHSA money passed through the state Office of Mental Health, further passed down through the city Department of Mental Hygiene, Health and Mental Hygiene. So we are really dependent on the federal government to step up here. So, okay, so that's my lay of the land as I said, as an outsider, as an advocate, and as someone who has worked on other successful health and justice movements coming into the serious mental illness space, the mental health space, and saying, why does it have to be this way? That's my motivating orientation is, does it have to be this way? And why does it have to be this way? And how can we change it? I was really taken by Fountainhouse when I was recruited for the process. And I went through a very long recruitment, 7 months, because I wasn't sure, they weren't sure. We were really feeling each other out to understand what the fit would be. But one thing that kept me coming back, despite my questions about the organization and where they wanted to go, was the model itself and the beauty within the walls of this place. You'll see our new mission statement. It's very much our new vision. We're turning into, from a local mental health provider, community mental health provider in New York City, we are really growing towards a national mental health nonprofit working to improve health, increase opportunity, and end social and economic isolation for people living with serious mental illness. We're specifically remaining focused on serious mental illness, not because we only provide services to those folks or that the definitions are DSM categories or any of those things. It's that we really invest in the idea that people with significant functional impairment due to mental health conditions, due to mental illness, can actually recover and regain function and reintegrate into society, that they don't have to be institutionalized, criminalized, neglected, or simply reverted to acute episodic engagement with our healthcare systems in order to survive. They're not castaway people, they're not throwaway people as we as a society have treated them, not you so much, but writ large. And they're actually people who have the opportunity to live better lives if we can create the conditions around them that foster that opportunity. We were founded in 1948 by people living with serious mental illness in conjunction with their social workers. These were 5 people leaving Rockland State Hospital and basically asking that very central question of, what do we do now? Nobody wants us, our families don't want us, can't get a job, we can't go back to school. So what did they do? They founded a members only clubhouse. This is I guess the kind of thing you did back in 1948. You created an eating club, or you created a private members only club. So they created a no cost private members club where they could congregate in a safe place by choice. I think you, as clinicians and as researchers and as people engaged in mental health, I think you can appreciate, particularly for SMI, that the thing that is snatched away from people by virtue of the illness or illnesses and by society's subsequent stigma and discrimination is choice, the ability to make choices for yourself. And Fountainhouse has always centered that idea that you're here because you want to be. You're here because you're here by choice. And as soon as you don't want to be here, you don't need to be here, because we believe you can make decisions for yourself. And that's proven to be over 7 decades, over 7 decades, a pretty good way to keep people engaged, as opposed to forced treatment, mandates, and punitive measures. We've said, look, you want to be here, be here. You don't want to be here, you're not ready. And we'll help you get ready. But as soon as you want to be here, this is what you have on offer. And what we have on offer is very much the community as therapy, where we've created a structure, a clubhouse, we call it, environment, which many of you will be familiar with, where skilled social practitioners really accompany members in their recovery. They're not treatment providers. one of the things I remarked upon when I visited Fountainhouse for the first time is I didn't really know who members and who staff were. They were all dressed the same. They were just engaged in community work. They were all actively and intentionally working. It wasn't just people sitting around, and that was also quite distinct from other day programs and other recovery institutes that I've been to. It was not passive. It was very engaged. It was buzzing. I called it like the Grand Central of serious mental illness in New York City, because it very much felt like there was a lot going on. We've always been centered around this notion of work, not so much work for monetary or for remunerable work in a classic sense, but rather work as activity and engagement. We've centered our day and centered our activities around work, but increasingly we've built pretty strong educational programs, wellness programs, and we have seen that this community, this hub, this place where people go for safety and socialization, is the conduit through which people stay durably engaged in healthcare, durably engaged in housing, and where we provide them with other aspirational outlets to take back their lives, to rebuild their lives. Because we know that the thing that really shortens lives, reduces the quality of life, is not necessarily the disease itself, but the debilitating social isolation that results from it. Right? And the medical neglect, the health neglect, the social neglect, and attendant risks and impacts that come along with that. So we know that creating this community hub where social isolation is broken every single minute of every single day, even just through your presence there, is a keystone to long-term recovery in the community. I would be remiss if I said why I came to Fountainhouse didn't involve the fact that this clubhouse model that Fountainhouse originated was present all over the country, all over the world, in fact. I didn't really come to run a direct service agency in Manhattan and the Bronx and in other sites around New York City. That's not my background, and it's not where I find I can have the most impact personally. What I did see was the massive potential to take a model like this and make it standard practice and make it standard of care and a destination for increased investment as an alternative to the status quo, which I think we can all agree isn't really working. It's not working on health measures, on economic measures, or any of the other data that I previously shared. So it's not simply that we have a building and we are not just creating a nicer, kinder form of mental health institution. That was one of my worries, in fact, was that weren't we just institutionalizing people all over again in a different way? And I came to realize that there was so much intention and design behind what's done at Fountainhouse that has been that really hasn't, disseminated out into the literature widely enough. And that's part of our responsibility, is to really lift up what does social practice mean? What does it mean to create an environment of social practice? What does it mean to conduct social practice? And it's really based on 5 tenets. One is social design, creating a physical environment. The physical milieu therapy is obviously an important piece of what we do there, but it's not the only piece. Using the the socialization and the community environment to engage people. I think you've all seen as clinicians the level of demotivation and loss of confidence that really plagues people with serious and persistent mental illness. This mode of consistent engagement is really our means of breaking out of that demotivated, low confidence state. Small things. There's a great story. One of my program directors said when this gentleman came in his mid-30s, he had been out of treatment for better part of a decade, and was very skeptical. Arrived in the lobby and had also co-occurring substance use issues, and just kind of sat in a corner. And the program director said, "Hey, how you doing?" Engaged him, and then said, "Hey, I need to go run an errand. Can you pick up some dry cleaning around the corner?" And gave him $5 to pay for the dry cleaning. And the gentleman's response was, "You would trust me with $5? You would trust me to go around the corner and pick up your dry cleaning? You would trust me to come back with it and not screw it up?" And that was deeply therapeutic for him. That was just the activation energy he needed to continue to engage in an environment where we're truly investing in these people. We believe that they can be more than what they are at their lowest moment. And I just thought that was a really beautiful anecdote of what Fountain House embodies. It's of course about relationship development. I've talked about Fountain House, like really building the skills for people to break out of their shells, to break like chicklets, like chicks breaking out of their eggshell. Each day is another crack in that eggshell. Each relationship they're able to build is another way for them to break out, and over time that accumulates and allows them to really break free in many ways. There's obviously continuous assessment and intervention. Mental illness, as you well know, is not static, it's dynamic. People have their ups and downs, and our social practitioners, social workers, many of them, not all of them, social workers, are really expert at deep observation, accompaniment, and designing interventions around that. So it does require a depth of engagement. It's not passive. You can't go sit in an office and just let people mill about. You've got to be engaged and active. And we happen to select for people who want that kind of engagement and want that kind of consistent activity. And of course, we create transitional environments, not only through our transitional and supported employment programs, which partners with 40 employers across the city, like Citibank and H&M and the local coffee shop, Cafe Grumpy, but also with a host of environments that we've built ourselves, like our gallery, our clinic, our FQHC, our farm program, which puts people in different milieus that are not specifically designed for them and allows them to understand how to interact, how to engage, how to build resilience, how to modulate their behavior in ways that, the illness has kind of interfered with that development at times. So those are really the principles of what the model is. The sociologist Eric Kleinenberg at NYU, he writes a lot about social infrastructure, right? It's a Voltairean concept of using places and locations to bring people together and to form community hubs. That's what we're really offering at Fountain House and at clubhouses all across the country and the world is community and social infrastructure, a place, a hub inside communities where people can go to by choice, with agency, with intention, and stay connected. In business speak and colloquial terms, when I'm talking to kind of healthcare investors, I'm like, we're sticky. That's really what we are. We're a sticky, highly engaged population. Our loss to follow-up rates are low. And that's because people want to be there. And the second they don't want to be there, they're not there. It's different to healthcare. It's different to housing. It's different to benefits programs. Nobody wants that. They need it. They have to go. They know that it's important, but they don't want to be there. I don't want to be there when I go to the hospital. I don't want to be there, right? Unless I'm seeing patients. So, I think we need to start centering our dialogue around recovery, not just on what's the common minimum and the basics of what people need to live in the community and recover, but what do they want to do? What can they do by choice? What's motivating and aspirational in addition to the basics? We also understand that there's a dynamic here. We can't exist in isolation. The history of Fountain House and the clubhouse movement has very much been anti-clinical in some ways, as an alternative to the medicalization of behavioral health and of SMI. And I don't think that that's particularly helpful, given that in this current environment where we understand that this is a partnership, we understand that this is a system of care that needs to exist, that healthcare benefits when folks have a therapeutic community. And in turn, our folks stay more engaged in primary and behavioral health care in the community when they're highly engaged in a clubhouse. Same with housing programs and a whole host of other benefits. But as far as the sort of three legs of the stool, the core package of interventions that we've found, and certainly here's an implementation science study, if you ever wanted to do one, is to look at the attributable impact of these different interventions and to try to convince the public system that you can't invest in one without the other. Fountainhouse is truly an alternative, and it works. We certainly have to do a lot more to build the research base here. It's surprisingly weak in some ways, but the data that we do have is pretty compelling. Whether it's our rates of housing and homelessness, over 35% of people have a recent history of homelessness, and within a year they're all stably housed. 99% of them are stably housed. For high need, high cost patients, we did a Medicaid analysis with the NYU folks at Jim Nickman and the NYU folks formerly of New York State Health Foundation, and found that when engaged in a Fountainhouse program, that folks' healthcare costs utilization went down by 20%. Hospitalization rates also went down. We have a significant population that's been justice involved and been previously incarcerated, and our recidivism rates are less than 5%. And of course, our employment rates are twice the national average for SMI, and 90% of our members engaged in educational programs are actually completing semesters of work in higher education. So we have much more to do on evaluation, much more compelling data to build. But I think one can argue that there is an evidence base for investment into social practice, into clubhouses at a level that's much greater than current levels of investment. I sort of belabored this. There was a meta-analysis a couple of years ago about clubhouse research across decades of studies, and just the employment, hospitalizations, and quality of life indicators, as well as increasing research around metacognition. I think that'll be interesting to a lot of you folks on the clinical side and behavioral side. We just published a study on metacognition and sort of insight, and showed significant gains when engaged into community-based programming like ours. And so I think we're just scratching the surface, I think, on data, and we have a lot more to do, and I'll get into that. But I think one cannot argue that there's not an evidence base for this. We have to invest more. It's a limited funding pool. I talked about how little funding's actually out there, and I'm just focusing mainly on public funding here, except for the last bullet. But you can only really build money for healthcare, for mental health care, on defined grant and federal programs like VA and IHS, reimbursements, Medicare, Medicaid, and CHIP being the main ones, grant programs like the block grants that come out of SAMHSA, the substance use and mental health block grants. And of course, there's adjacent funding from criminal justice systems, housing systems, employment systems, and educational systems as alternatives to status quo investments, which aren't really working. Of course, there's a huge effort now, or growing effort, I should say, to get private philanthropy more engaged. We, in the last year, have gotten money from places like the Ford Foundation and Robinhood, and we're in discussions right now with Gates, because they're finally seeing that this is a public health issue that and a justice issue that they need to be investing in. None of them really have a mental health strategy. Melinda Gates and her arm, Upswing, just did their first investments in mostly youth mental health. But we're talking to them also about what about that core community health infrastructure that models like Fountainhouse can be a part of. And so, but it's a limited pool, and we have to shift the economics of this system. We have to grow the resource pie and also slice up that pie in ways that fundamentally, shift those resources to evidence-based community mental health systems. And healthcare is only one part of that. And it's taken me a long time to figure that out too, working in resource poor settings and likewise to really understand that healthcare is a sine qua non, but it's not enough. It's not sufficient. And unless we're making these other investments, healthcare will continue to sort of chase its tail, particularly on issues like serious mental illness. I think there's obviously fantastic work being done in your own department and by folks on early intervention, which I think offers a ton of promise and not something we're focused on so much here today in this talk. We are working currently to try to unlock more resources for Fountainhouse and for models like it through VBP arrangements, and I can describe that later, value-based payment arrangements, through ACO work that we're doing in Cleveland with our affiliate there, through behavioral health waivers, the 1115 and 1915B waivers that we're part of applying for in California, and through advancement of enforcement of parity laws and other strategies. We're also exploring becoming a CCBHC to be a recipient of that funding as well. And so we are exploring this, and programs like ours need to respond to the system as it is, while also advocating for more investment into new ways of doing things. And I think we've started to see early returns. I've been in my job for 18 months or so, and have been advocating to the city. Obviously, I came from DOHMH, so I knew a lot of the folks involved, but through a combination of policy advocacy, data, and really a crisis of, I think that we're all seeing in our mayoral race come up over and over again around mental illness and homelessness and the like. We just recently, at the end of April, unlocked a 50% increase in funding for Fountainhouse and clubhouses all around the city. And that was directly due to our advocacy with, I guess now it's no longer called Thrive, but whatever it's called now, Office of Community Mental Health, I think. So this is a drop in the bucket. There's ways to do this, and we're engaged in discussions in Washington, but also in places like California, Seattle, Texas. Texas is surprisingly, kind of far ahead on mental health investments into communities, in large, not always due to the right motivators, but they've got significant funding, and folks like Meadows Institute down there and Andy Keller are doing really fantastic work to get the ear of strange bedfellows like John Cornyn and others. So, we know, and I've said before, that research is really foundational to making all of this work. We were very blessed to get within a few months of my arrival, within 6 months of my arrival, a new grant for $3 million to establish a new research department at Fountainhouse, building off of existing research partnerships we have. I'd love to put Columbia front and center as well on this slide, because I think there's just enormous potential to build out evaluative research, implementation research around a model like Fountainhouse, to appeal to, in particular, public sector policymakers and resource allocators who are making investment decisions, but also systems like NYP and NYU and Mount Sinai, who are also struggling to provide high quality care for people with SMI. And so we're really pleased to be working with Health First right now on a value-based payment contract, both for our in-person and our digital services, and I think that's just the start of developing the kind of scalable reimbursement models that we can be using across the city and across the nation to drive more investment into community-based alternatives for people living with SMI. I think there's a real lack of data in this entire segment of psychosocial rehab. The quality of the data is really quite poor, to be honest. And so whether you're a fan of the PROS model or Clubhouse model, as I look at these different or one-on-one peer-led engagement models, the data is sparse, and we need some consolidation here and some agreement that there are principles around which we need to organize. And I think social practice offers up a framing for that. It may not be the only one, but until there's good data around how to keep people, what's that sticky form of engagement in communities for people who are prone to isolation, prone to falling off the map. In health system terms, what's a demand aggregator? I hate that kind of language, but it's a very business focused view. How do you actually get people to make themselves visible and to remain visible in a congregate way? in communities, so they don't end up having to be, so they don't end up falling victim to our punitive systems that end up institutionalizing them. I don't want to belabor this. So where are we headed? What's the next step for Fountainhouse? And I think as I alluded to, I saw the potential of this model in large measure because without a ton of investment, without a ton of attention, and with relatively sparse data, relatively sparse, certainly when benchmarked against other public health interventions, definitely sparse, it was able to scale to over 200 communities across the US, 37 states, and in 30 countries. So I recognize there's got to be some real power in this model. There's got to be some real insight that people are seeing that is causing them to invest and build these replications of Fountainhouse in their own community. So I said, what if we built a centralized kind of organization to help advance this entire movement? So we're really organizing ourselves around hope at the individual level and community level, expanding our direct services, justice, changing the narrative and really securing a seat at the policy table, and partnership and solutions. We know that our future, we can't secure our future financially or from a scale perspective unless we partner with healthcare and partner with adjacent providers like housing and so forth. So those are the sort of three principles we're focusing on. Our direct services will continue to advance the clubhouses themselves, and as I alluded to with the New York funding. But importantly, and maybe the only signal I'll send, but it's really an important part of our thinking going forward, is how can we actually take on a more of a public health approach by intervening early? How can we focus on younger people who are bearing the brunt of the pandemic and who have been bearing the brunt of our mental health epidemics for so long? And how do we actually show that we can make significant gains and redirect trajectories? And how do we do the research around that? Well, at least at an early phase, for about the last 6 years, we've run a college reentry program for students 18 to 30 who have dropped out of college or grad school due to mental health issues, and basically wrapping them around with the same kind of community program, social practice programming, now delivered virtually. And about 90%, 89% of our students get back to school within a year. And I think we all know that completion of school and completion of educational goals is really deterministic in terms of long-term health and outcomes. Health from a broader perspective, outcomes specific to their mental health conditions. And so we think that this is an area of really increased investment. We just signed a partnership with Estee Lauder and Joe Malone to try to scale this at 8 sites around the country. And so, I mean, there's a ripe opportunity for research and evaluation around a program like this. I think we're also looking very deeply into other priority populations, including people of color, including people involved in the justice system and homeless, as well as veterans groups. We've had a veterans program for some time. Lori Sutton, who was the former commissioner of Veterans Affairs and candidate for mayor, worked closely with us for some years, but again, was never really developed. Program development hasn't been a focus for a place like Fountainhouse, in large measure because there hasn't been great modes of investment into those programs. So we're building out a national affiliate network. As I said, there are over 200 of these clubhouse programs across the country. Not all of them are independent. Some of them are run by hospitals. Some of them are run by other agencies, nonprofit agencies. And so we don't have control or the ability to partner with all of them right away, but there are about a third of them that are independent. And we're starting the process of affiliating those independent community mental health projects, those clubhouses around the country. And we started with 8 communities. And we know that whether it's scaling new programs and innovations, building a national data network, expanding our ability to raise money nationally, and doing advocacy and campaign work, that we're much better and stronger together. In that way, we're really moving towards a future where we're going to organize ourselves a little bit like the Planned Parenthood for mental health. And that is to say, that our work in communities, our ability to affect change in individuals' lives and in community lives, is our platform to really shift the narrative and to shift policy and civil rights for people with serious mental illness. I talked a lot about driving investment into mental health and how do we change access to these programs. But you can't really answer that question unless you ask, why is it so bad today? And I truly believe that stigma and discrimination are at the root, structural stigma and discrimination, not just interpersonal. Structural stigma and discrimination of mental health is at the root of why we have underfinanced mental health so dramatically to date. And so it's going to take not only new data and research and new models of growth, but advocacy, real engaged advocacy. And that really starts with centering the people who, with lived experience, who are affected most. And so that's really what we're working to build at Fountainhouse. And we're on our way. We just finished a year-long strategic plan with the Bridgespan Group, and now we're launching a massive national fundraising campaign to make this a reality. We're building a 501c4. For those of you who aren't familiar with that, that's a political advocacy and education organization that's able to engage directly in our political system. It's not good enough to say we're just producing the data, or we're just advocating, or we're just designing new policies. The field of play, especially today, is our political system. If we're not working with candidates, working with voters, working to educate people about the issues and how they affect people with serious mental illness, we're missing an opportunity to really work on all of these different outputs, as you see on the right-hand side. And so we've said, we're not going to shy away from that. We're going to build it. And so we're launching that in the fall. I want to be mindful of time. So this is only to say that we're building out the kinds of partnerships that I alluded to. Healthcare is a massive one and a principal one, whether it's through contracting mechanisms or through our digital and hybrid analogs that they can reimburse for and partner with. That's going to be a major vertical of our growth. This money is not going to appear from nowhere. And the resources to expand these programs have to come from where some of the resources are currently, and that's in healthcare, and from a system that's really struggling, I think. As I talk to health system leaders, they're struggling to provide good care to people with SMI. Health First, the payer we're working with, Managed Medicaid, is struggling to engage their high-risk behavioral health cohort. So if our comparative advantage is engagement, then why aren't we partnering with them? That's the question I was asking. And so we're starting to build that. And I won't belabor this further. I think what sets this apart is that at the center of all of this is the lived experience of our members. And they are there to fuel this culture of innovation and evaluation, but also to fuel the advocacy. It's much more powerful to hear the story of before and after from a person who's lived it than from me or from anyone else, you know? So we really are working to build a member advocacy base that's rooted in lived experience. Our history of collaboration and partnership with people and with other community partners, I think is a sort of great foundation for success. And, you know, as I said before, we are going to take this on in all of the dimensions of public policy and public health that it needs to be addressed in. And only then are we going to be able to unlock the kind of change we're seeking. So I have a few more slides, but I think I will stop at the moment and open it up to questions, because I want to leave enough time for questions. And I'm happy to share slides and to continue the conversation thereafter. But
thank you so much, Dr. Vasan. That was a really inspiring presentation, and I just have to say you did a masterful job of, you know, presenting kind of the seriousness of the issues and the problems that we need to address without pulling any punches, but also really giving us a sense of an important path forward and how we can start to make a difference. There's a bunch of questions from folks listening in, but I wanted to first give Dr. Lieberman a chance to comment.
Ashwin, Wonderful presentation and really a grand vision and very inspirational. I have two questions which are succinct but difficult, I think. First, why is there such an exceptionalism to mental health? I mean, you don't see anything happening with other disease areas. Maybe AIDS was an exception when the AIDS epidemic hit, but other disease areas, sectors of healthcare don't require this kind of a ground up individual effort as opposed to some policy driven top down effort. What's the exceptionalism? What is it based, the philosophical reasons for that, or societal reasons? And then secondly, your financial model. So there's no, I mean, we run our clinical services based on a business model, revenue streams, et cetera. How do you manage the financial model to do something which everybody would agree is in the best interests of our population and our society, but may not have a readily identifiable financial source?
Yeah, so the first question I think is both complex and simple. I truly believe that the inattention, the lack of investment, and the historical neglect of mental health systems comes down to stigma at a systemic level. It's our interpersonal view of how we regard mental health and mental illness, particularly serious mental illness, but in general, that has infected our society. It's infected our public policy as an extension of that, and it infected the resource allocation decisions that result from that. And that might sound simplistic, but it's deeply complex, right? Because I look at myself let's start at the individual level, and the way that I stigmatized and discriminated against my own family members. I was taught in my culture that it's weakness. I was taught that mental illness is an individual failing, atomized at the person level, and that only the person could recover from it. And only the person had the agency to change, and that there was no structural or cultural or societal or even family component to it, that we weren't the causes of it or impacting it, that it was really the person. And that was born of ignorance. It's born of culture, and born of a shame that is attached to mental health that has not gone away yet, but it's starting to change. I mean, I think you're all aware of the tennis player Naomi Osaka, who just withdrew from the tournament. She called out the system. She called out the press and the organizers of the tournament as exacerbating her already vulnerable mental health. Who is a part of the solution set there? Is it all on her to improve her mental health and become more resilient to an unchanging system? Or is it on the system to tackle where it might be driving in ways that are direct and indirect the worsening of her and the mental health of athletes of other kinds? And so I think that's one explanation. Why has there been this neglect? And coming from HIV, honestly, I see so many parallels.
Ashwin, I hate to interrupt, but there's so many questions. I don't
I'm sorry.
I don't want to
to the financial model piece, Jeff, I think that's why I really focus on reimbursement and opportunities to unlock reimbursement. We are currently, psychosocial rehab in general, Fountainhouse specifically, and clubhouses are illegible to health systems. We are not a normative part of community-based solutions. And frankly, community-based solutions writ large are not normative parts of healthcare reimbursement yet. And so value-based arrangements like this, also the ACO work that we're doing in Cleveland with University Hospital and Case, is a great step forward and a potential to really change the paradigm of how they can pay, particularly in a downstream risk capitated model where managed care is saving money based on how much inpatient and emergency care is averted. We have a role to play in that.
The only thing I have to say is I have to get you to talk to our hospital administrators. Over to you.
Yeah, I always get to the wrong person. I get to like the community solutions person, but I need to talk to the business folks.
So there are a bunch of questions, so I'll start with this. So Nicholas Benitez Harris writes in, this is an excellent model and very promising. It's already expanded to over 200 locations. Given the millions of people with serious mental illness who need services, there still seems to be a discrepancy between need and supply. Is the solution primarily to expand existing sites or create new ones, or both? If you're able to secure sufficient funding, how will the supply of mental health workers and social workers expand to accommodate the massive need?
It's a fantastic question. It's going to be nigh on impossible to do this in a bricks and mortar kind of way. We're not going to be able to build new clubhouses and programs like this all across the country. We've got to really make the principles and tenets of social practice and expand the presence of these clubhouse recovery models as much as we can. Currently, there are 13 million people with serious mental illness. Let's assume that a third of them are so marginalized that they need something like this, right? Now, 80% of our folks are on Medicaid and they're very vulnerable, but let's just assume a third, right? Even then, we're barely scratching the surface. Clubhouses across the country only serve about 65,000 people. So we're nowhere near close to meeting the unmet need. So the question is well taken. I think we need to grow in the physical environment a little. We need to infect systems and really become standard of care through these reimbursement contracts so that other agencies take on this model. We need to build digital solutions particularly for higher digitally literate people living with SMI, which we found there are plenty. And, that's a start. It also works. It has to be a partnership with healthcare and with housing. And so it's also about working with housing providers, expanding affordable housing and entering those spaces and building the sort of community solutions that we're good at.
Great.
Sorry, I didn't address the health worker need. That's a massive issue and not one we're addressing right now.
Maura Baldrini writes in, great presentation, thank you. It appears that with this type of program, you're almost providing the person a new family or social network. Can you please speculate on the possible theoretical framework that would explain the basis of why such an intervention is working so well?
I mean, we're biologically social creatures. We're hardwired to be connected to other human beings. And when a disease state compounded with stigma and discrimination leads you to be so socially and economically isolated that you no longer have connection to people, then I think there's your theoretical framework. It's about rebuilding connection and breaking social isolation. There's a whole host of literature on social isolation independent of mental illness that says it's equivalent to smoking like 15 cigarettes a day. And so I think that's really the framing here. We're breaking social isolation, social and economic isolation, and providing that kind of social infrastructure and community hub for people. You're absolutely right, though. It's very much like building a family. People regard Fountainhouse as their family, and some people come to their family every single day, and some people come once a month. And that's really, it's there when you need it.
Myrna Weissman writes in, what do you see as the highest priority research area needed?
I think that basic evaluative science around why this is a savings, not just an economic savings, but a health savings, a opportunity savings, why coming from the outside into this work and understanding that stigma and discrimination is driving so much of our public policy making around mental health. The first thing I ask myself is, how can I put this problem into terms that others will understand? And so it's wonderful if we look at this from an individual outcome and clinical disease state perspective. But unless we're talking about how it's reducing recidivism, reducing homelessness, reducing economic isolation, and improving health and saving lives, increasing life expectancy, I think we're missing the public health opportunity here, because no one really cares whether metacognition improves. To be perfectly honest, no one in public policy cares. They're not going to give you money on that basis. They're not going to build more clubhouses on the basis of you having, more aspirational self-efficacy, even though we know how important that is in the etiology or the theory of change for the model. So I would say that it's implementation science and evaluative science that needs to lead the way.
On that topic, Ralph Wharton asked if you could clarify what you mean by recidivism. Are you referring to rehospitalization, jail, return to psychosis?
I was referring to criminal justice, so reincarceration in that specific example. But we have data on all of those other. We don't call that recidivism classically, but yeah, I have data on those and happy to share it.
William Tucker writes, how do you encourage mental health organizations to take on the problem of providing housing? For example, becoming housing first models or providing behavioral health care?
Absolutely. We at Fountainhouse, actually, it's not well known, but we're one of the largest supportive housing providers, transitional and supportive housing providers for behavioral health in New York City. We operate about 450 beds through buildings that we own. And then we work with another 100 folks in other people's housing. And so that might sound like a drop in the bucket. It certainly is compared to the need. But whether you look at our organization, groups like the Jewish Board, groups like Community Access, there's a lot of behavioral health housing out there. Actually, the system is so Byzantine and hard to access for people that every single night in New York City, there are empty behavioral health supportive housing beds because the access to those beds and the barriers to entry and the hoops that we make people jump through are just so limiting and so off-putting and dejecting and rejecting that we actually have housing stock available to us, let alone 20% of hotel beds in the city are unused every single night. And so I'm encouraged by folks like Gavin Newsom in California, who's actually saying, well, look, if you're not making money on this hotel, let the state reappropriate this to behavioral health housing and to homeless, well, really to affordable housing for homeless people. And so I think that housing has to be front and center, which is why we make it a part of our community model. But we have also found that it's not the only thing. It's the floor, it's not the ceiling. Let's say that.
Asha Ratnasamy Kennedy writes in, lovely presentation, very important message. How do you think this can be applied to countries outside of the US? Is this model able to carry beyond Western society? Another listener actually wrote in about a similar program in Japan.
Yeah, so there are clubhouses in 30 countries around the world, in addition to the United States, Canada, a lot of Western Europe, but also the first fountain house outside of the US is in Lahore, Pakistan. There is a fountain house in Cape Town, South Africa. There is a fountain house in Calcutta, or a similar name, I forgot the name, in Calcutta, Hong Kong, Taiwan. So we are focused right now currently on the domestic elements because we understand the resourcing of it better than we understand global mental health resourcing. That's pretty complex and very different country to country. But there's an organization out there. In fact, Fountain House created this organization called Clubhouse International. It's a small nonprofit focused on that exact question. How do you disseminate this model internationally? And so there are people interested in this. They just don't have the resources or the juice to make inroads. And so, but it's changing. In Norway, there are 25 of these clubhouses, and they're considered standard part of their community mental health system. So there are examples. In Sweden, there are 10 fountain houses in the local language. I think it's something like Fountainhuset or something. But it's a great thing, right? But it needs to be brought together in a kind of coherent discourse and with a coherent funding model.
Great. So we are just about out of time. So I think that would have to be our last question. But I, again, wanted to really thank you, Dr. Vasan. It's really inspiring work and inspiring presentation. And to really hope that, as you had alluded to, that this could sort of be a jumping off point for more bridges between Fountain House and Columbia Psychiatry.
Yeah, I'm just so grateful to be here. It's obviously a little intimidating to be talking to a bunch of experts as an outsider. But, I hope that my comments were received in the spirit that they were intended, which is really, I'm trying to answer the question of why does it have to be this way? And I really want to change those conditions. And I hope you'll join me. And I think there's ample opportunity to collaborate. So I hope you'll be in touch. My email is, maybe you can send them my email. It's just ashwin@fountainhouse.org.
Okay, wonderful. Yeah, thank you so much. We definitely learned a lot from you. I really appreciate you taking the time, and hope everyone can join us next week for our departmental meeting. Everyone have a good day. Take care.